Good morning. The Carol Stiblow Public Health Prize acknowledges a health worker or a community organization for contributions to TB control over a period of 10 years or more. Nolin Dirkse has made a real difference within her community, particularly for people with HIV, AIDS, and TB. She's been involved in many community projects and workshops in and around the area of Knysna, a small town in the Western Cape of South Africa. Many residents know Nolin as the woman with the oxygen tank, since Nolin has very little lung capacity left. Her battle with TB started at birth when she was diagnosed with tuberculosis in her feet. And since then, she has been diagnosed again with TB 10 times. Despite her poor health, Nolin strives to give her very best in life and to make a difference, helping people discover who they are despite their circumstances. She's a motivational speaker, providing workshops and doing all she can to assist people diagnosed with HIV, AIDS, or TB, and particularly those without adequate health care. She's founded her own NGO. Because of her poor health, Nolin is unable to accept her award in person, but it gives me great pleasure to invite her colleague, Veronique Klein, to the stage to accept the Carol Stiblow Public Health Prize on Nolin's behalf. Veronique.
Thanks, Dr. Nan. Now I would like to introduce myself because I will chair the session. I'm Dr. Esti Febriani. I'm from Indonesia and work as technical TB advisor at Lembaga Kesehatan Nahdlatul Ulama, the biggest Muslim organization in the country, and represent communities in TB response in collaboration with the country national TB program. I'm also a lecturer in the Faculty of Public Health, and I also serve now on WHO's Civil Society Task Force. In today's live streaming plenary, we will hear about two innovative and different solutions in public-private partnership from Korea and India. And after that, if we have the time, I will ask a few follow-up questions to the way forward. Our first speakers will be Dr. Hongjo Choi. Since 2015, he has headed the research center of the Korean Institute of Tuberculosis. He will speak on public health partnering with the private sector, a case study from Korea. Dr. Choi, please welcome.
Good morning, everybody. I'm Hongjo Choi from South Korea. It's my great honor to have an opportunity sharing Korean experience. Today, Today, I would like to talk about the achievement and challenge of the nationwide Korean public-private mixed program in the public perspective. I've received a research grant from a pharmaceutical company. I would like to start with the previous situation before Korean PPM launched. This was a national TB program structure around the 1980s. Under Ministry of Health and Provincial Health Division, health centers and their branches played a major role of the patient care and management. And there are two levels of supervisory committee to provide technical support to the health center and their branch. For the TB diagnosis, as the only part of private sector within NTP, Korean National TB Association, Korean Institute of Tuberculosis, and their branches conducted sputum examination. And there are 3 national TB hospitals to hospitalize chronic TB cases who require the long-term care. As you can see from the picture, there was no position of a private sector within NTP, only except for Korean National TB Association. This is a snapshot to understand previous environment in South Korea. South Korea established national health insurance in 1977 and extended the coverage to entire population in 1989. In terms of TB management, all diagnosis and treatment was free within NTP, which means public sector. But a patient who wanted to be treated in private sector should pay out-of-pocket cost. The range of out-of-pocket cost about 30% of total medical cost. This is a statement of a patient who admitted in a national TB hospital and protested against the privatization of the national TB hospital at that time. One of the main reasons of the protest was high medical cost in the private hospital. So we can simply understand the situation at that time. Even though there was no position of private sector within NTP, some TB patients must be treated in private hospital. This is a study to understand the real nature of a private TB clinic before 2000. As you can see from here, the lost follow-up rate was higher in private sector than health centers. Lost follow-up rate was about 33.6% in 1987 and 27% in 1993. Moreover, some private hospitals are unlikely to follow national and global TB guidelines. So, meanwhile, Korean health system was changing with economic development. As I mentioned before, national health insurance introduced in 1977 and extended the coverage to entire population in 1989. Basically, the NHI has a co-payment system. So the proportion of out-of-pocket payment was gradually decreased from 60% to the 40%. In the TB service, all cost was free in public sector, but 30% out-of-pocket payment in private sector. Even if there was out-of-pocket payment in private sector, patient preference to choose treatment institution was changed with economic development. So almost 50% TB patients treated in private sector in 2000. So there are several kinds of problems. To solve this problem, Korean National TB Association studied to develop a conceptual framework of the Korean public-private mix. The study focused on how to share the role between public and private sector. This picture includes all activities from case detection to the case management, case notification, and other administrative works. There are several kinds of ways to share roles between public and private mix. If we choose A, private sector conducted case detection only, but the other work should be managed by public sector. If we choose D, private sector perform most activities, only except for case notification and other administrative works. In this report, researcher suggested C as the best option, which means private sector treat TB patient and public sector conduct case management. After introducing the conceptual frameworks, Korean Institute of Tuberculosis conducted a pilot project of the public-private collaboration in 2000 and 2001. The pilot project adapted the option C. Trained public health nurses were dispatched to the private hospital and performed health education and case holding activities. The outcome of the project was ambitious. Treatment success rate was higher at 91% in intervention group compared to the 75% in control group. The treatment success rate in intervention group even was higher than health center. We had a positive outcome, the pilot project, but PPM could not be introduced without political commitment, as you well know. Now I would like to talk about how PPM introduced and what we achieved from the nationwide public-private mix program. This is a brief timeline of public-private mix. As I mentioned before, the KIT developed the conceptual framework in 1997 and completed a pilot project in 2001. 2 years later, Korean CDC created, and the role of national TB program was changed from the Korean Institute of Tuberculosis and to the Korean CDC. 3 years later, Korean CDC announced a TB elimination plan to reduce TB incidence less than 10 per 100,000 people until 2030. Finally, policy window was open to launch public-private mix. In 2007, a new pilot project conducted by Korean CDC. In 2009, Korean PPM was launched with 22 major private hospitals where treated more than 250 TB patients in a year. In 2011, the coverage was extended to 97 private hospitals where treated more than 100 TB patients in a year. This is a PPM mechanism. Korean CDC contracted with Korean Academy of TB and Respiratory Disease. And the academy generated PPM unit and manages TB patients by trained TB nurses. We called PPM nurse. PPM unit covered 70% TB patient. Additionally, the other 30% TB patients were managed by health center. So a health center provided a direct service to the TB patient and supervised other small private hospitals. So theoretically, the Korean public-private mix program covered 100% of TB patients. All healthcare workers trained by Korean CDC and KIT, and clinical guidelines published by Korean CDC and the Korean Academy TB and Respiratory Disease. Here's just a summary of PPM introduction. There were problems in private sector, including high lost follow-up rate, and there were a couple of political opportunities, including a new KCDC creation. Moreover, there was a favorable environment to introduce public-private mix because all private sector covered by national health insurance at that time. So, as the last part of my presentation, I would like to introduce the impact evaluation of the Korean public-private mix. We collected all information of notified TB patients from the TB surveillance system in KCDC, and we constructed 2 retrospective cohorts. The first cohort includes new TB cases who registered in 2009, and the second cohort includes new cases who notified in 2014, with 5 intervals to the first cohort. To avoid difficulty to interpret results, we excluded multi-drug resistant TB cases. Theoretically, health center could not be influenced by public-private mix program because PPM program focused on case management in private sector only. So we decided to compare treatment success rate and lost follow-up rate of private sector during 5 years interval with health center. So we considered health center as a control group and private sector as an intervention group. We conducted difference in difference analysis. As you know, it's not feasible to construct longitudinal data set with repeated measure in the TB study. So we added propensity score matching methods to generate the quasi-counterfactual control from between 2009 and 2014. Various covariates were used for the matching entirely. Finally, we include 33 32,591 and 32,791 TB patients included in 2009 and 2014 cohort. Among them, about 6,000 and about 3,000 TB patients treated in health center in 2009 and 2014. This is the result. The left side is a crude analysis, and right side is PSM analysis. The red line indicates treatment success rate. Oh, yeah. There's a number was disappeared, but I will introduce. I will explain it. And blue means lost to follow-up. The solid line is public health center, and dot line is private sector. As you can see from the graph, the most gap between between lines are decreasing during 5 years interval from the 2009 and 2014. Maybe you can imagine the number is under X bar, yeah. And in particular, the improvement in private sector is much faster than health center. 7.6% more increasing of treatment success rate in private sector than health center, and 11.9% more decreasing of lost to follow-up rate in private sector. So we identified a similar trend in PSM analysis as well. This is a subgraph analysis with the same methodology. The left side indicates treatment success rate. The right side indicates lost to follow-up rate. Most subgroups presented significant improvement of treatment success rate and lost to follow-up rate. However, old age and culture-positive group may not improve treatment success rate during 5 years public-private mix experience. Moreover, there were more deterioration of treatment success rate and lost to follow-up rate among people who experienced at least one transfer out during treatment period. So TB patients who wanted to change their treatment institution showed lower treatment success rate and higher loss to follow-up rate, even if nationwide public-private mix program fully operated. So, to summarize, we obtained several lessons from the impact evaluation. First of all, nationwide PPM achieved more improvement of treatment success rate, loss to follow-up rate in private sector between 5 years implementation. Therefore, the most gap between public and private sector were eliminated. Moreover, national health insurance must provide a favorable environment for the achievement of public-private mix, because the proportion of out-of-pocket payment was decreased from 30% to 5% in 2011 and 0% maybe in 2016. This may reflect there must be a strong synergy between public-private mix and universal health coverage. Of course, Korean PPM achieved a lot of improvement, but have some challenges. The increased NIH, National Health Insurance coverage may affect the change of patient preference and healthcare workers' mind in health center. More patients were treated in private sector, and simultaneously, the capacity of public health center might be weakened due to no more TB patients there. Secondly, public-private mix is highly hospital-based approach, so there is a lack of a community-based approach within NTP. This may be a cause of higher loss to follow-up rate among patients who experienced transfer out during therapy. And what if those patients between hospital would be more vulnerable group than others? So currently, Korean CDC and KIT are conducting community-based TB support project to fill the gaps. I appreciate a lot my collaborators in my institution, Korean CDC, Korea University, and Johns Hopkins University. Thank you for your attention.
Thank you, Dr. Choi. Our next presentation, titled Private Sector Partnering with Public Health, a case study from India. We'll open with a 5-minute video from Dr. Naresh Trihan, who could not be here today to give his presentation. He is a cardiovascular surgeon by training. He is the chairman and managing director and chief cardiac surgeon of Medanta, the Medicity, with 1,500-bedded multi-super specialty institute, which offer cutting-edge technology and state-of-art treatment facilities at an affordable cost. Responding to the government of India's call to action on TB, he has spearheaded a project in the state of Haryana to increase diagnosis of TB using mobile phones, with plans to expand to other areas. Following his words, Dr. Bonani Datta, the Director of Respiratory Medicine of Medanta and lead for TB Haryana, will present his project, which she herself actually designed and has run for the last 5 years.
Good morning. I am Dr. Naresh Trihan. I am the chairman of Medanta, the Medicity in Gurugram, which is NCR Delhi actually. Sorry, I am not able to make it to this meeting. I was very keen to do so, but because of the conflict with our opening our second facility in Lucknow, which is a 1,000-bed hospital, which is also coinciding with the same dates, that it was not possible for me to be with you. So I am going to give you some brief outlook of what we have been doing. Fortunately, Dr. Bonali Datta, who is the real champion, is going to be there with you. I am just an accidental TB warrior and will continue to be so. I received an invitation to the Mumbai Dialogue, and when I inquired from the US ambassador what this Mumbai Dialogue was about, he told me that it's about TB-free India. So the flashback came that Dr. Bonali had already done something which I didn't know, so I requested her to brief me on what her study was and what was the result. So she said that they had done a controlled trial in conjunction with the local Haryana DOT officers. They figured out that 50% of the patients who were suspected to have TB, they would go undetected because their sputum would not show mycobacterium. And you needed, and as an additional diagnostics, was a digital X-ray. An analog was not clear enough to diagnose. So I said, fine. That means that if we assist the government in its effort for TB control and treatment, which we describe as the DOT program, and just this little intervention that we provided, the digital X-ray first, and then came the CB-NAT also, that if we created specialized vans which could go and assist by rotation every area where there were suspected patients of TB but could not be detected probably, we could help to detect them. That's the intervention Dr. Bonali Datta and team took. Now this we financed from as our CSR from Medanta, the Medicity, and also from donors from around us who were well-meaning and wanted to participate in this TB control program. So when I went to Mumbai, I had back of the envelope said, with the current incidence of TB in India, Haryana probably has somewhere between 25 to 50,000 patients. And it would be possible for us to cover all the 23 districts of Haryana over a period of time. And I must say, you'll get the details from Dr. Bonali, who's the champion. I am the person standing behind her and giving her whatever support, because I am a believer that she will share the details with you. We have covered, I think, 18 or so, and we are rapidly moving to the next few. Now, needless to say that this has been a very gratifying journey to see that the intervention that we are doing has had so much impact that we have been able to actually sift out people or patients who otherwise would have got undetected and infected another 10, 15 people in their lifetime. We think that this intervention is essential, and hopefully will spread throughout India. And not only have we then almost covered Haryana, but we have become emboldened to take this program to other states. So right now we've had a conversation and a sort of a early agreement with the government of Jharkhand, with Madhya Pradesh, with UP, and there is some demand from Meghalaya. And we are moving along Meghalaya very rapidly because the Chief Minister is very proactive. So we are going to start these programs in all these 5 states in addition to Haryana in this coming year. So that's what I wanted to share with you, and Dr. Bonali will do the rest. Sorry again that I couldn't make it. Please have a great conference, and I'll get the briefing from Dr. Bonali when she gets back. And we want to now go over one of the things that I forgot to add was the fact that we want to do an outcome study while we are doing all this effort, and we are adopting a block which is Pataudi, which is near us, and Dr. Datta will also give you the details of that in her deliberation. Thank you very much, and hope to be able to attend the next meeting. Thank you.
Thanks, Dr. Trihan. I feel that he is with us today. Yeah. Next, I would like to welcome Dr. Datta to present it.
Good morning, and it's an honor to be here on behalf of Dr. Trihan and Medanta, the hospital I work in, and Dr. Trihan's already given an overview. And I'll just take you through some nitty-gritty of the entire sort of thing, how we started. So the focus in this, Dr. Choi gave a very comprehensive national kind of data, and ours is, the focus is going to narrow down just to this project mainly, but the fact that it has scope, significant scope and scale. No conflict of interest to report. Private sector in India is this, array of different players, right from the unqualified practitioner down to pharmacies, nursing homes, and then high-end corporate hospitals. And the importance of this is that 2/3 of our patients will first seek healthcare advice from a private sector, most often the individual practitioner. So in any case, this is the range of private practice we have. And while RNTCP, which is our national TB program, has an overarching influence by way of the flow of how things happen in the TB field, in the entire private sector, the corporate sector, both corporate hospitals, healthcare, related corporates, and corporates via their CSR, that is the corporate social responsibility budgets, can actually bolster the RNTCP very effectively. And that, I think, needs to be tapped into effectively. And that is and that is the purpose of what we have done. Mission TB-Free Haryana, as has been told, is a public-private partnership. And this is the evolution of what was started in November 2015 when we launched it. And we aligned ourselves with our RNTCP, worked closely with them, and evolved with the program. When we first started, it was passive case finding. Then we went on to enhanced case finding. And now the focus very much is on active case finding, and that's what we're going to start with our block. So when we did our pilot in 2014, this was the algorithm, the diagnostic algorithm for pulmonary tuberculosis in our national program. And it was, of course, the smear was the cornerstone of diagnosis. And only when the patient had repeated negatives was chest X-ray recommended. It was well at the bottom of the algorithm. X-ray facilities have been not available in the districts, in the peripheries, and that's where our mobile van with the digital X-ray fitted in quite well to complement the existing system. So passive case finding, and this was what our first van looked like. This is the interior with a digital X-ray. We could see it on the screen, print it out, and have a fair idea of where things stood, especially for the smear negatives. And this picture has been shown. This is us working closely with the district TB officer. When we launched how we envisaged Mission TB-Free Haryana was to have, this is the map of Haryana. It had 21 districts when we started. Now there's 23. And we divided them into 5 zones, just in terms of proximity. And we thought of having 5 vans which would cover each of these zones in a cyclical manner. and that would go on for a 4 to 5 year period. And when we started, we had a hub and spoke model. So Medanta Hospital is based in Gurgaon, and there were 4 adjacent districts that we covered. This was all timetabled. The timetable was made by the district TB officer who had the actual know of the area. And while this was a good model, we realized that turnout for the camps was really not good enough, and it had to be better considering how much resources was being channelized into that. Around that same time in 2016, our diagnostic algorithm changed. And of course, WHO's focus changed as well, and they recommended chest X-ray now as a screening tool to be used. In keeping, our program now pushed the X-ray up right to the top. So if a presumptive patient came to you, not only was smear done, but also chest X-ray were available. So no extra facilities were provided, but we could go ahead and do it. We didn't have to wait for repeated negative smears before we could do it. And then was the introduction of the CB-NAT or the gene expert, which I think was a tremendous game changer at every level of TB diagnosis. This led us on to enhanced case finding, which essentially meant that we just tried to mobilize the community, spread awareness that the van would be coming and anyone who was chest symptomatic presented. So pamphlets, banners, and using the help of our grassroots workers, the ASHAs, who are essentially the link between community in the rural communities and healthcare services. So we would dedicate anything between 3 to 6 weeks to a district, and we would go, again, PHC-wise, CHC-wise, covering the entire district. And once that was covered, we'd move on to the next district and then return. And again, the key thing was to create a lot of awareness ahead of the camps so that people were aware that this van would be coming and then they would present to us. So this was in Mewat, which is a district in Haryana with exceptionally high TB load, and we had a very good turnout that time. So we continued along these lines for the next 3 years. And the result of the 3 years, the pilot was the first year, 2014, and that's a single district. Then we went on to 5, then 13 and 16, and this year we've covered 17 districts. And just the top zone, the northern districts are yet left, but we hope to do that in the next year. And the results as well, we've sort of increased the numbers screened. Roughly 30% of the population that we have screened of chest symptomatic come out to have abnormal X-rays, and around 10% of those screened then go on to the DOTS program, and that has been the overall sort of experience we've had. What changed things significantly was the addition of the Gene Expert Edge. Now the X-ray, the difficulty with X-ray, as we all know, is that it's highly sensitive, very poor specificity, and medical officers in the primary healthcare centers often don't know how to interpret it, and that is a problem. So the program often discourages the use of chest X-ray as the final diagnostic tool, and there's good evidence to support that. So while we were doing X-rays, there would be times when we couldn't really push through the diagnosis. So that was changed by the Edge. So the Edge is the Gene Expert. It's the very same thing, except that it's a single module, and it was developed for its portability and sturdiness. So it comes in a case, and then we'd carry it in the van, and then when we reached there, we could open it out, and then the ones where we felt chest X-ray was strongly suggestive, we'd go ahead and do it at point of care. And again, that's vital because often we find in these districts, the patient will come to you once, and that is your one chance to sort out the diagnosis because you don't know if the patient will return because distances are immense, and that's what we face. So then that's what we started doing. Chest X-ray, strongly suggestive, would then undergo a CB-NAT at the same time, then and there. And these are just examples of X-rays which are strikingly abnormal, and we've done a gene expert test and detected low with RIF resistance, and this is again another one detected high. So in a 6-month period that we used the Edge, which was this particular single module CB-NAT, we screened with chest X-ray 1673 patients. The total CB-NAT done was 176, and total detected was 82, so very high. So when there is a strong clinical radiological suspicion, I think CB-NAT it corroborates very well with a positive CB-NAT result. So 47% positivity rate, and we diagnosed 6 MDRs. So it may well be that they all would have got diagnosed eventually, but we don't know when that eventually is. And I think ultimately we just reduce the delays in diagnosis, which is one of the key reasons why the TB sort of keeps perpetuating. Now coming to active case finding that Dr. Trehan briefly touched about. Now along with the program, now the emphasis is on eradication, and then it's active case finding with door to door. Then you can't even leave out a single household. So Pataudi is a block. Now Gurgaon is a district, and within it we have our city Gurgaon where our hospital is based, and Pataudi is a block close by, 40 minutes drive from us. And a block is much more contained. So the census back in 2011 was 3.5 lakhs, which is 350,000, and but realistically it's probably closer to 600 to 700,000 people. So it's screening all of them and then identifying them for sort of X-ray and CB-NAT and smear. Now, the only difference at this is that we really want to engage community in this. So we have the government driving it, we have NGOs, we have the private sector now, buying into this, but the community, till they take ownership, I think we will not be able to eradicate it. And in our case, community is vast because, our population is so enormous. So we have done multi-level meetings, and this particular one is very good because we have the ASHA workers, we have sarpanchas who are the local leaders. They are the sort of the smallest unit of government in the village. They are the leads of that. And it is essentially to just draw them all into this program. The method is simple. It's door-to-door questionnaire with the volunteers. We will engage volunteers with ASHAs, and then the ones who are chest symptomatic, ask them to present to the camp. The mobile van will be taken to a far more remote location so that they have access to it. We have yet to start. We were going to start in October. There was elections, and so it's been deferred to mid of November. And we hope to sort of achieve the first round in 6 to 7 months, and then pause to see the effect, and then repeat. And this, will go on till till elimination happens. And we hope to essentially develop a cost-effective model that can then be scaled up. Engagement of other corporates, and this I think is a key role played by Dr. Trehan because vans have been given to us by different corporates, Siemens, Oriental Bank of Commerce, RJ Corp, Wrights, Philips, and then Medanta has fabricated them and run them. How we have managed to engage them, again, I think effective leadership by Dr. Trehan, having credibility as an organization, working closely with government, and then demonstrating a model that works and that has been successful. We are one of the first partners that the union engaged in the call to action when Dr. Trehan went for the Mumbai dialogue, and the union have been strong partners and catalysts in everything that we have done. We also pledged as one of the corporates in the USAID corporate pledge event held recently in Delhi. Now the way forward as we tackle our block is to increase our remit. So far we've just been diagnostic led, and we do the diagnosis and we step back because the government has everything else laid out. But we feel now more engagement is needed, and essentially we have to complete this loop, the entire continuum of care. So starting with awareness through diagnosis, treatment, adherence and completion, which are, again, key things, and then going on to behavior change campaign. And we hope to achieve this in our block because we now have a consortium of partners, and that GE who are, technological partners. We have the union as knowledge partners, KPMG as monitoring, etc. And this may be the way forward, small consortia who have a skill mix. And that, I think, will lead on to being able to sustain this as well. So our consortia has clinical, technological, social, financial facets to it, which will then lead on to innovations. Now, innovations is, of course, the buzzword, but I feel strongly that we also need to effectively use what we already have. We have X-ray, we have smear, we have CB-NAT. I mean, this is pretty good, a good armamentarium for diagnostic, and I think we just have to use it effectively. And then funds, of course, CSR funds, it's mandatory for all corporates to contribute, and I think we do need to tap into that to ensure sustainability. Scaling to other states was also mentioned, and this is the plan around March to go on to 4 more states other than Haryana. And I've just highlighted Meghalaya because that's a state in the northeast part of India, and it's an extremely hilly terrain, so very different to the plains that we live in. And the challenges will therefore be different. So we actually paid a visit in August to Shillong with our RNTCP team to thrash out a few things. And just to point out, the challenges faced. So Meghalaya, it's a small state, as is Haryana. Meghalaya is half the area of Haryana, but has 1/10 the population. So the population is very scattered, sparsely distributed. On the same token, the population of a village in Pataudi in Haryana or Gurgaon would have 2,400 people, inhabitants, and a village in one of the districts of Shillong has 475. So, you know, the van will have to just traverse far more to reach everyone. So I think the challenges are different in different areas. We have done research and publications. We published the pilot with the union and then a cost effectiveness study. And just recently, 5 years of this PPP was in the Indian Journal of Tuberculosis. So this is work in progress. So overall, I think we have developed effective partnership with a lot of support of people around us, you know, the government, most of all, for allowing us to work with them and work with them closely. The private sector is us and others who have joined up with us, and the NGOs. The union have been, as I've said, very strong force behind all of this. We have a committed team on the ground who work well beyond their call of duty, because they do long hours, arduous hours out of the hospital in sort of 45 degrees temperature heat and things like that. But they've sort of continued to do it, so that's great. And then finally, effective leadership. And Dr. Trehan calls himself an accidental warrior in this battle against TB, but clearly none of this would have happened had he not backed it and supported it with his with his position where he is. Thank you very much for your time.
Thank you for both of you that already gave us a few with what you already did in your country. And you show, in your presentation, you show how the partnership between public and private can increase the big achievement, especially in the case detection. And I would like to ask some questions, especially for Dr. Choi. You mentioned that there's still the remaining challenge in terms of the loss to follow up to the patient. And you mentioned also about the lack of community engagement, and it's one of the challenges. Could you please explain what kind of challenges for you, for the country, to initiate the community engagement in your country? So for Dr. Datta, is also the loss to follow up is still a challenge in your country, because you didn't mention too much about this area. Thank you.
Thank you for the question. It's a complicated issue. Several kinds of issue combined within the first question. But as I mentioned before, the Korean public-private mix is highly hospital-based approach, which means no more TB patient in community-level health center, and a lot of patients visited and treated, managed in private sector, which means the capacity of the public health center is weakening. And the physical distance between the hospital to the community is so far. So if there is no structure of a community-based supporting system, there is very difficulty to generate community engagement within the national TB program. So currently, the Korean CDC is planning quite a couple of community-based projects. For example, active case finding in the community-based strategy, and to develop the community support, TB support program in the community level to reduce, to filling the gaps between the patient who are transferred out during their treatment period. Yeah, because it cannot be solved within the hospital-based approach that we think. But one more thing I would like to talk about, the challenge in the Korean public-private mix is about the informal employment of the PPM nurses. Yeah, because the budget for the salary is supported by Korean CDC, but each hospital, private hospital, hired PPM nurses by themselves. So if there is the biggest hospital already the PPM nurses incorporated into the permanent employment, but the other hospital hesitate to formalize the PPM nurses as their permanent step because there is some kind of fear of the sustainability of the budget. That would be some challenge in Korean public-private so far.
So thank you for the question. So loss to follow up, right? Yeah. No, absolutely. So that's a very big problem in India, and because treatment adherence, I mean, the treatment is difficult as it is, and for patients to adhere to the treatment till completion is not easy. Now, as I mentioned, we have so far just engaged up till diagnosis, up till doing, diagnostic aids, and the reason for that is, again, it is a mix. We're meeting the government halfway, and it's important to also, draw lines as to what our task is and what the government service is already providing, and that's why we haven't really gone into this. When we tackle this block, which is a much more sort of defined area, we hope to be able to do more, more community engagement, more maybe follow-up clinics for ensuring adherence, for doing liver function tests, or whatever may be needed to ensure that they don't default because of the side effects, which is typically what happens because there's no support then to see them through that.
Okay, thank you. And then in terms of the sustainability of the partnership, what do you think? Maybe about the commitment, local government commitment, also the private commitment. What can you share with us?
So right now we are, the emphasis on TB eradication is enormous. And the government's announcement to do it, to at least try to do it 5 years ahead of WHO targets to eradicate by 2025 TB in a country which has 25% of the world's burden. So that's a tall task, but it has given tremendous impetus to everyone at every sort of point. I've never heard TB being, and I'm a pulmonologist, I'm a clinician that's been working in chest disease and TB for a very long time, and I've not heard so much focus on TB from every quarter. So we engage closely with a lot of other private, private companies, corporates, and all of them are much more sensitized. So I think now is the time that we really need to capitalize on this impetus and just draw everyone into it. For the next 5 years, I think everyone will be, very committed from all aspects, and then we have to see what we have achieved at that point, and then understand how to sort of take it forward. I mean, the government's commitment, of course, is very obvious. They have taken some tremendous measures. They have sort of nutritional support to patients, apart from giving free treatment for ever since the national program happened, to give them nutritional support. So every patient gets 500 rupees every month to help them just get that extra bit of nutrition necessary to improve immunity and deal with the disease. And so I think there is a lot of sort of support and interest at the moment, and we hope to make it last for till it takes for us to get there.
Recently, Korean government released the second phase of the national TB strategy with 5 years interval. So within the second phase plan, I think political commitment is very supportive to progress the current national TB program, such as the management of multi-drug resistant TB cases and the vulnerable population. They focused on vulnerable population, and then I mentioned before they also think about develop a community-based TB treatment support unit. So far, the only thing I would like to emphasize the government should be considered is the social protection, I think. Yeah. If I mentioned before, the direct medical cost already 0% due to national health insurance covered every stop. But the other part, in particular the indirect cost, is not considered within the national TB program so far. So that must be the next step of the Korean government.
Yeah, thank you, Dr. Choi, Dr. Datta, for your good presentation and sharing with us with your insight And I think that based on our discussion this morning, we conclude that the partnership between public and partnership is a must. So because from your presentation, from the case study, we can see the big impact of this partnership. So we should keep our effort to strengthen this partnership. And even we still face some challenges, so don't give up. We must be innovative, being creative to find another solution to resolve the problem. So, sorry, I think we have not enough time to open the discussion. And thanks for your attention. Thanks for both of presenters. And let's continue our effort to fight TB and end TB in the world. Applause to the two great presenters. Thank you. Have a nice day.